Okay.
Hi everyone, this is Howard. I'm moderating this week. Jeff is away. Travis will start this week. Travis, great, go ahead. Yep, we see your screen.
Okay. This is a quick one, and it's much a curiosity. This is a patient I saw this morning, and just I know Howard especially likes to show new types of devices, and this is one I'm curious if you've ever seen before. But I noticed this. He's got an endotracheal tube, and then as you zoom in, it looks like it terminates here, and then there's this other fragment of similar density right there. And he had just gotten transferred from an outside hospital, and you'll see on the outside radiograph that it looks the same. So I was less worried about it being something, the tip of an intra-aortic balloon pump just randomly hanging out there. But it turns out this just looks like some sort of new endotracheal tube, which I've never seen before. It must be just a different manufacturer. I'll show you on coronal. I'm just curious if you guys have seen this.
Don't think so.
It did bother me at first, but if you look here at the tube, you'll see that there's that distal portion right here, and then you see more proximally right here. I can MIP it up. So I have no idea what the manufacturer is, but it clearly looks like it's just got a gap. And I don't know if this is a side port or side hole in the endotracheal tube, or if it's just they intentionally manufacture it like that. But it's a new one for me that I've never seen.
No, neither have I. I've not seen that before or noticed.
Yeah, and I was looking at it more, and you can see the balloon often. And here I think we see the balloon the cuff is inflated above that level. So I don't know. I don't think it's a defect though. I think it's just how this is designed. So, and since it was done somewhere else, I have no idea what the manufacturer is or anything. But that's just kind of a heads up.
Okay.
For anybody else to see. All right, this one is a acute case, and I'll let you look at the radiograph for a second and see if you see anything. This is from July, and I can put the lateral up too. And, zoom in on the area of abnormality and we're looking at the hilum. This is a lady that has worsening respiratory symptoms, and
that's subtle.
Yeah, it's subtle. This is the retrospectoscope, because this was not seen prospectively.
One wouldn't.
And you can see and you can see on the lateral view, her left main upper lobe continuum here looks pretty good.
Yes.
So, and it's lower than that, but it's an interesting case too, because it's a somewhat unusual diagnosis. And I don't think I have her original CT, but I will tell you that a few months ago, she had a CT that was completely normal, like back in March. And now this is July, and she's middle-aged. She has a history of HIV, which was, actually, I will be able to pull up her old study and show you, because she had presented with an AIDS-defining illness a few months ago. I have it under a different name or a different MR number. But then she represented with this, and her airway was completely normal looking back. And of course, for some reason, they decided to do a PE study the next day. But you can see that she has this endobronchial lesion. There's some little bit of thickening of the airway here on the left. I think the left mainstem bronchus certainly looks thicker than the right mainstem bronchus. And this had grown over the course of a couple months. So there was some question about whether or not she could have a tumor. It's a little fast for a tumor. She has an inferior subcarinal lymph node here too. So they did a bronch and a biopsy, and this was not a tumor, it was necrotic, and they had granulomas, and this was actually endobronchial MAI. It was Mycobacterium avium, or MAC, yeah. So it was kind of an interesting presentation of that. I know we've seen cases of endobronchial tuberculosis, usually, more typically circumferential, maybe multicentric, but this was just more of a focal mass-like granulomatous infection of her trachea. So, and Howard, while you're showing cases, I can pull up her old one, since I've got it. I'd have to search through the other ones, but she had presented with pneumocystis pneumonia, which was a nice CT in its own right, but now has this endobronchial mycobacterial infection.
Gosh. Wow.
And I think the only real clue there is just the fact that it had grown from nothing over the course of a couple of months. So this is one that I did last week. I'm curious, Howard, do you guys do the biopsies at Utah, or somebody else do them?
No, our interventional radiology section does.
Yeah. Well, we still do gold fiducials sometimes, and we've got some other products that we're using now, but this is an adenocarcinoma that I biopsied and then was requested that we leave a fiducial in here. So here's the fiducial placement, and you can see it next to the lesion and next to the needle, so it's clearly out of the needle. And the technologist was even complimenting me on how nice and centered it was. Then, of course, the patient coughed, and here's the next image, and you'll see that the fiducial is now no longer in the lesion, but has instead decided to migrate into the main stem bronchus. So it's just sitting in his bronchus. I know I showed a case a few years ago of one that had embolized to the left anterior descending coronary artery. The patient was asymptomatic. This is the first one I've had in the fall into the airway. We've had a few that go into the pleural space, but this was didn't cause the patient any harm.
Yeah.
Then we placed this other type. This is the other one, this gold anchor that we place, and these will either coil up or you can kind of extend them along the length of a lesion. So this is what we're using now as a new thing, but it was just a coil or a fiducial. I don't know if you call it embolization or just falling out into the main stem bronchus, but here's the new one that we placed, and you can't really see it on here. Presumably he'll cough it out. I don't know if it's, that's up higher. He's had a bunch of surgical clips from other things. But this was an adenocarcinoma with just another variant of embolization of his fiducial marker.
Oh, okay. Wow.
This is another recent one, and I've shown a different version of this, I think I commented, this is as you can see, that he still has the TEE probe in, but they have cleaned or closed up his mediastinum. And I guess, I don't know the sequence of events, but they had an incorrect sponge count. And sure enough, here's this. Now, it's interesting, they've already closed up his mediastinum. So again, I don't know when they identified that there was a missing sponge, but what's nice that we do, and I think I showed a retained needle where we do the same thing, is our technologists will always take an image of what they're missing, so that we can compare. So this is part of the same study. I think it's a pretty good practice and has helped us with needles, trying to know what type of needle to look for, and in this case, a laparotomy sponge. So this one is kind of interesting too, because clearly they've gone back in now to remove that, because you can see that the mediastinal wires have a different configuration and a different number. There's 8 here, there's only 7 now. And I haven't had a chance to talk to the surgeon, and I'm not trying to accuse anyone of anything, but it was interesting that there was no mention of this in their surgical note, that they said the instrument count was correct, and never really documented this thing anywhere in the chart. It's kind of just swept under the rug in my mind, but clearly they've had to go in and revise this with the different configuration here. But I don't know. It's obviously a complication they don't want to have. There's no harm to the patient in this case. He also has an intra-aortic balloon pump that had migrated and was repositioned subsequently. But do you guys take pictures of things that are suspected to be missing?
Not really. I mean, the only ones that we typically look for in terms of sponges are the ones that I would recognize from here. It's the Raytech sponge and the lab sponge. The particular one that you're showing us here, I don't think I recognize that brand of sponge as such. But when you say the tech takes an image, they just take the same thing in the OR for comparison, a piece of the
correct. Yeah, this is just on a cassette in the OR, taken at the same time.
Yeah, yeah.
And I found it to be more helpful with, I showed a needle, and just to know the size of the needle, because they'll tell you usually if it's a 2.0 or a 4.0 or 6.0 or something, but it's nice to have the size comparison.
Yeah.
Just to know what exactly you're looking for.
Okay.
So it is a pretty good, I found it to be a helpful practice. Not that anybody would mistake this, hopefully, But I think having the comparison there just gives
Yeah,
you one extra layer of protection to notice it.
yeah, good.
So, and this one, you know, I was talking to some of my colleagues last week after you showed that huge papillary fibroelastoma that I still am have never really seen one that I was convinced was a papillary fibroelastoma on my own. Seth's shown them, you've shown them, and then this came in yesterday. One of my colleagues from the VA shared with me, and here you have this little nodule that's on the aortic valve. It's on the aortic side of the valve, and so it's most likely going to be papillary fibroelastoma as well. So this is more of what I typically think of in terms of size. Yours was obviously huge compared to this, but this is still presumed, but it's most likely going to be a papillary fibroelastoma.
Yeah.
And yeah, if you look in the literature, they'll say that vegetations usually occur on the ventricular side of the valve, whereas papillary fibroelastomas are on the aortic side of the valve, and that would fit with this. I don't know how hard and true that rule is, but you know, thrombus you could also conceivably have on a valve leaflet. But I thought this was a cute little one, and I'll wait and see if we get path on it. But just another example relevant to or pertinent to your discussion from last week.
I think when I was reading up about that, there was a mention of the notion of some of these that start off as a thrombus, and the genesis somehow involves a thrombus. And then there was a word that I'd never heard before that represent these small things on the valves called, if I remember correctly, Lambel's excrescences or something that surgeons know about that I'd never heard of before.
Yeah, LAMBL, isn't that?
Lambel excrescence. The small things on the valve leaflets.
Right. Yeah, they will describe it. Yeah. So that I don't know. I haven't read up on PFEs in a while. But yeah, I think it makes sense that they might form from thrombus.
Somehow.
I don't know.
Yeah. Maybe that's just a theory.
Yeah.
We don't really know.
I will stop there for the moment and gather some more while you show some.
All right. Oops. Okay, this is a young person. This is a remarkable case in the sense that I think it might be the second one I've ever seen. So let me show you this. She's an 18-year-old girl that presented, as best I can tell, with chest discomfort, and of course one understands why. I don't know if she had a cough or any other symptoms. So let me show you what this lesion looks like. It's large. It is perihilar. It clearly involves lung. There is pathology in adjacent mediastinum, a lot. Lymph node enlargement is part of it. Areas of low attenuation within as well. If I go to the lung window, you will see that there is mucoid impaction in bronchi. So clearly part of this is obstructing bronchi with mucoid impaction there. Up high, there are septal lines. So when I saw that, I thought, okay, there could be obstruction of lymphatics, or perhaps pulmonary venous drainage from the lobe is affected by the large mass, or combinations thereof. Up high up here, we catch the bottom of what turns out to be supraclavicular lymph node enlargement. I'll show you the PET now to show you that we do have FDG avid lymph nodes in the left supraclavicular region. We have a lot of FDG activity within the tumor. It's pretty extensive. So a very large tumor, already metastatic in a young person. Typically, if you say that without looking at images, you'll say, okay, is it in the anterior mediastinum? Is it a germ cell tumor? Is it a lymphoma? Differential diagnosis like that. But there's one other tumor that we've talked about before that this one turns out to be on biopsy. So this is, I'll put it up alongside here. It is the so-called midline nut carcinoma. And the images in this particular AGR are very similar. You can see it's a very large infiltrative tumor when it involves the lungs. Here's one lower down with similar kind of infiltrative features, very extensive tumor. Here's another one that has similar features. Now this nut tumor, I'll just bring this up, has to do with the fact that there is a gene associated with this, and there's a fusion of a gene, the nut gene, from one chromosome to another, leading to a fusion event. So this is very distinctive in this kind of carcinoma. And it turns out that there is a protein that results from this fusion rearrangement that is called the nut protein that immunohistochemistry can evaluate if you have that particular immunohistochemistry, if you have the ability to do that. So they sent that off to someone who does that, and it is positive, as you see here. So sometimes there's some hints on histology that one may be dealing with this tumor. And here you can see there's diffuse positivity for the so-called nut-related protein. So nut, I don't know why it's called that, but it's called nuclear protein of testis or something like that. Nuclear protein of testis, and I don't know where that came from. So I'm not sure, have you guys seen examples of this or tumors similar to this that has turned out to be this, or you think maybe this?
No, I've only seen that article. And yeah, I think you showed a case of it at one point, right? Already?
I think so, maybe some years ago. Yeah.
Yeah. And because they occur midline throughout the body, right? Isn't that the idea?
Yeah, in the sino-nasal region, salivary gland, neck, chest, primarily. Yeah.
Yeah, I would have never guessed that in this case.
Yeah, I think, it's so sort of distinctive in a way that it's in the differential in a young person when you see a tumor that looks like that, as it turns out. Yeah. So unfortunately, the prognosis is quite awful. That's the horrible part of this. There's nothing that really works. Okay, I'm going to show one that I showed. Well, let me show this one. It's a cute case. Good. So this is a bedside radiography. Ignore what's happening in the chest, the lungs, and the heart. But after seeing the lungs and the heart, I noticed something and I thought, what is all that about? So let me bring the left shoulder over here so we can concentrate on the findings related to the upper left chest and the shoulder girdle. So what I noticed was there is a lot of atheroma, calcified atheromatous plaques in this subclavian axillary artery. They are surgical clips. Looking at the bones, these look quite different from the other side. There is some rarefaction and some irregular sclerosis in all these bones. And the other thing that you can see is there's asymmetry of the soft tissues in the supraclavicular region. So then, of course, I went to the medical record and found out that indeed this patient did have radiation therapy in the 1980s for a tumor that was located somewhere about the shoulder and involved axillary lymph nodes. So I think we have accelerated atherosclerosis, asymmetric because of the radiation. We have some chronic radiation osteitis, if you want to describe it in that way. And apparently he couldn't move his arms, and they wondered about his brachial plexus, the integrity of his brachial plexus, and I think they've blamed that too on the radiation therapy from the 1980s. So quite an interesting combination of findings that one can come up with an explanation for. Okay, show you another one. This is the one that I shared with some of you guys some time ago. So this came in as an interstitial lung disease imaging protocol, and scrolling through there, we get to a point here where there are these very strange parenchymal reticular opacities, quite coarse, just confined to that portion of lung. And then acute image to bring up alongside that one is this one. And you can see here on expiration how his lungs herniate transcostally, intercostal, transcostally into the chest wall. So we have lung herniations. And then looking at this some more, you can see that the muscles here are very thin, the intercostals, and maybe some serratus as well. So I never found out the reason for this. I think putting this together, we can blame this fibrosis, if you will, localized to the herniations, chronic herniations. But I try to get a history of prior surgery, coughing, weightlifting, something that rendered these muscles very, very thin. And I couldn't, from the medical record, find anything.
Does he play the trumpet?
Trumpet? No, I don't. No, I couldn't find that. Who knows? Not that I saw, David. So really interesting, very curious. And when the clinicians came over, I just had to reassure them that this wasn't diffuse fibrosing disorder, of course, and otherwise just a curious combination of findings.
Huh.
Quite remarkable, isn't it?
Yeah. So some bilateral symmetric chest wall defect here. What does his diaphragm look like? Is it
Let's go down here.
It's kind of thick there on the right.
Yeah, I don't know. Is this a little bit too thick? Maybe there, plus minus.
Yeah. I wonder if yeah. Okay.
I don't know. I'm going to have to go back and see if they ever figured out where he does something unusual that might have caused.
I just really would wonder if he plays an instrument that involves, generating a lot of high pressure and trying to blow it through. So, maybe an oboe. An oboe requires a lot of forced expiration. Somebody referred to the oboe as an ill wind that nobody blows good because there are so few good oboe players.
I like that. Isn't that interesting? It's almost as if there are interlobular septa that are thickened by whatever that stuff really is in there. Very curious.
It probably is rubbing over the over the edges of the defect and going back and forth. It's a little bit like the traction, that osteophyte that you get with the fibrosis and the
something like that.
Lung.
Yeah. Oh, one thing I did notice in his note after I spoke to them was an addendum they put there, and they discussed this. And then he apparently said that, yes, he has noticed sometimes bulges between his ribs that he pushes back. So the patient has noted that something bulges out sometimes.
Huh.
Maybe he's just gotten used to it, that he, quote, pushes back sometimes, or he could push it back. So he definitely feels something there. It's curious.
Yeah, this is remarkable because we see little herniations in patients undergoing or after they've undergone lung transplant, and sometimes you'll see a little bit of reticular opacity, but I've never seen a case this exaggerated.
Yeah, very curious. Let me see who else who's on, and then I can show some more too. We have Brent. Do you have cases you want to show, or David, or otherwise I can keep going with Travis?
I have a couple if when you get to a stopping point.
Okay, I'll stop here. And are you ready, David? Here you go.
Let me see. We're okay now.
Good.
Sorry.
That's all right. I can check that out.
So here's a young man who presented. This is about a 10-year-old case, and I was stimulated to look at this case again because of the case I showed a couple of weeks ago when a man had diffuse bronchiolitis that looked just like Travis's cases of synthetic marijuana use. Turns out he uses real marijuana, this guy from 2 weeks ago or 3 weeks ago, and he likes to do it as dabbing, which means that he concentrates the marijuana resin by extracting marijuana leaves with the butane. It's a sticky mass that's about 80% tetrahydrocannabinol, and then heats that with a blowtorch on a piece of metal and sucks the smoke and the vapors through a water bath. And this whole process is called dabbing, because they take a dab of this resin and then heat it on that piece of metal called a nail. So he had a diffuse bronchiolitis pattern that was concentrated in the bases. Now this fellow whose radiograph you're seeing currently is from 10 years ago, and he was also a marijuana user. We don't know what other exotic paraphernalia he might have been using in his marijuana use, but he came in with his respiratory distress, and it was never really established what was wrong with him. But he had this radiograph and this CT scan, and you can see that this is outside CT, and there's a lot of motion artifact here, but he's got this nodular, central lobular nodular pattern where you can see it without the motion artifact. It looks a lot like our current case, and it's basal predominant, the way our case was 3 weeks ago, and the way Travis's cases were, showing this intense bronchiolitis from synthetic marijuana use.
Yeah.
So in retrospect, this fellow who admitted to using marijuana, I think cocaine as well, may really have been an earlier case of, marijuana inhalation, maybe with some device that added some corrosive stuff to the smoke or something like that. And he had a lung biopsy, and he was diagnosed with this, with AFOP, so acute fibrinous organizing pneumonia. There were little pellets of organizing pneumonia throughout his airways, and they formed these very firm little blobs like this. So this pattern persisted for several weeks in him. You can see this is later that month, and then it's fading by the end of the month and getting a little bit better. And then we skip to a couple months later, and it looks pretty good at this point, maybe just a little bit of nodularity left, but he had a CT scan that shows there's still some central lobular faint peri-airway abnormalities. Yeah. So I don't have a firm diagnosis as to what triggered this lung damage in this guy, this AFOP pattern in him, but I think it's very plausible in light of Travis's cases and our recent case that this might have been some smoking related phenomenon here. And then a few months later, he presented with what was diagnosed as Goodpasture's disease. And Sudhakar has pointed out that people who smoke have an increased rate of Goodpasture's disease. And it may be that some sort of lung damage from cigarette smoking and maybe from marijuana smoking as well exposes some basement membranes and some collagen, and then antibodies develop against those basement membrane collagen components, and that could lead to Goodpasture's disease with attack on the basement membranes in the kidneys as well as lungs. So an eventual Goodpasture's diagnosis in this fellow.
Wow.
And then as far as I know, it all went away because we've lost, or at least we've lost contact with this person after this 10-year ago episode. Okay, so I'm presuming that this was a bronchiolitis leading to AFOP, probably associated with marijuana smoking. There was no infectious agent ever identified, and nothing else was put him at risk. Okay, so let me show you another case here. This is a pretty normal looking chest radiograph. There may be a little mediastinal convexity at this location. Nothing for sure. It could just be the main pulmonary artery. But this fellow's CT scan shows a lesion in the region of the thymus. He's 21 years old at this point. And this is a bit too much thymic tissue. And this was enhancing quite a bit. So his CT scans were showing an enhancement of like 81 Hounsfield units with the injected contrast here, which is, I think, more than thymus does. He also has an excess of lymph nodes in his axilla and also in his groin. So he has got inguinal nodes here. And these are also, in several of the CT scans, were quite enhancing quite a bit. He had a node biopsy at one point that led to the diagnosis of Castleman's disease. So this is multicentric Castleman's disease in this fellow, and I haven't read his history yet, so I don't know what risk factors there might have been for this. He was, and I also don't know what his treatment was, but his course was benign, and after a few years, he disappeared from our system. So this is, I think, multicentric Castleman's. I'm not sure that I would distinguish this from a you know, a large thymus, maybe some 21-year-olds do have a large thymus. It looks a little convex and firm. I think the enhancement is helpful, but I would rely on your guys' experiences with thymic enhancement. Thymus gland itself or thymoma, how much does it enhance with contrast? Did anybody have a clue?
Thymic hyperplasia shouldn't enhance, one would think.
Yeah, that look right there bothers me.
Yeah.
Okay.
It seems too convex as well, that it's
too firm.
Yeah, and it seems like it's single lobed as opposed to just draping over the mediastinum.
Got it. Okay. Well, I think this is one of his Castleman's lesions then, and so
yeah.
You know, one thing I would think of if he had anything to suggest excess steroids, I would think of maybe an ACTH producing thymic carcinoid or neuroendocrine tumor of thymus that would enhance, maybe that was secreting peptides like ACTH, for example, I think, or an enhancing lesion that looks like a mass. Yeah.
Got it.
Trying to think what else.
Okay, those are the two cases I scrambled together.
That's really interesting.
Those are great.
Yeah. Okay. Travis, can I go back to you and then I can show a few more perhaps?
Sure.
Okay, here we go.
David, some of the marijuana cases we had did have organizing pneumonia on the biopsy.
Right.
And I'm pulling up this case. Oh, I guess I didn't. This is not marijuana, but this is one from San Francisco General from a few years ago. Again, striking diffuse centrilobular nodules, very similar in appearance.
Yeah.
And this is a patient, and I don't have access to the path. I only have what my colleagues have told me. But this is a patient who is a hookah smoker. And they did a biopsy and they got this foreign body granulomatous reaction, presumably to some of the oils or something that is aspirated or inhaled from the hookah. And so this was a case that, we've been calling it hookah lung, but it's very similar, just probably a bronchiolitis, and in this case, a foreign body reaction in the airways.
Yeah.
Okay.
So I don't know if you've ever seen that or not, but if anybody has, again, just another exposure that you can have that can cause this bronchiolitis and reaction.
San Francisco is leading the way, so we'll probably see it eventually.
Yeah, so I thought that was a fun one, and your case reminded me to pull this one up because I had saved that one to show it. All right, let's see. Let me go here, and this is the lady who had the endobronchial mycobacterial infection. This is her earlier this year, or I guess last year. But this was 2014. She was normal, and then she came in April of this year, and you can see now that she has, symmetric, hazy opacities, kind of busy. Maybe you can tease out some little discrete reticular opacities. And this was her AIDS defining illness, came in. And so just show you quickly, it's a nice example of pneumocystis pneumonia, which was confirmed that there's, mostly just ground glass, some reticulation, a little bit of architectural distortion. In some areas, it's more perilobular, but absence of smooth interlobular septal thickening, absence of peribronchial cuffing, absence of effusions. You're not going to go with heart failure in this case. And her left mainstem bronchus is completely normal in this case. And so this was 3 months prior to her presentation with this new endobronchial lesion after they had started her on therapy. So
very interesting.
Yeah, now let's go back to this one. And this is just I guess, an unusual or uncommon appearance of a common disease that we see. And this was the patient's radiograph when they came in, and just diffuse nodules, except when you look, they're not really miliary. Some of them are larger, and then you see there's this more discrete area of consolidation. And you get more history. This patient isn't really that sick. They have a cough. but certainly it's not going to be some raging bronchopneumonia where you would expect them to be sick. And then this was an outside CT, and you can see that it's pretty impressive. And this is perilymphatic, I would say. Some of the nodules are along the lymphatics, and then it's a lot of peribronchovascular nodules, and they're kind of ill-defined. It's almost ground glass in all of these locations. And then there's this more discrete mass in the middle lobe. And it's diffuse, maybe a little bit more upper lobe predominant. But yeah, this was originally, you know, the outside hospital, I give them credit, they thought this was going to be diffuse lung cancer, less likely sarcoid. And this did turn out to be adenocarcinoma. So just kind of an unusual look, but you know, one of primary lung adenocarcinoma that's gone everywhere. And I guess probably that mass in the right middle lobe is the source. But here was more recently, and now she's left with some areas of scar and architectural distortion. Now it looks almost more like an interstitial lung disease, except you can tease out a couple areas where you might have some small little Cheerios and other lesions. But it's kind of cool that this responded, and some of these just left with little holes from areas that were treated and responded to therapy. So really bizarre look, but one that, again, you know, adenocarcinoma just continues to show up in different ways.
Yeah. Do you perhaps know whether this one was EGFR positive and the patient treated with an inhibitor?
Yeah, she did have an EGFR mutation. And so I don't know, I'll have to look and see what she was treated with, but she did have a mutation.
Yeah, because you can see the opacities on the right-hand side after treatment look very strange. And I've seen that too in patients with diffuse adenocarcinoma treated with EGFR inhibitor. When they come back, they have these diffuse opacities that are hard to describe. It just what they look like here.
Yeah, I mean, this looks like, without the history or without the priors, you would consider that this could be an interstitial lung disease. I mean, it's unclassifiable, but there's a lot of architectural distortion. But then the more you look and you start to tease out little nodules.
Cheerios and cystic spaces. And
yeah, it's a really bizarre look.
Yeah. Gosh, that's, yeah.
But I thought this one was just interesting because it almost looks more like a mucinous adenocarcinoma, just how kind of hazy and almost ground glass this stuff is, rather than discrete nodules and nodular consolidation. So just a bizarre look.
Yeah. You know, if you made fewer of those and you left them in the lung, just less of it, and the patient had HIV, I would think of Kaposi's.
Yeah. Yeah, that's true too. That you could have, that you could have just like little flame-shaped things.
Yeah.
Yeah, that's a good point.
Obviously, Kaposi's or lymphoma as possibilities too.
Yeah.
Because it really has that infiltrating look.
Yeah. All right. The next one is for David. He prompted me to rate our teaching file after last week. Just quickly show another case. This lady was 98 at the time of this radiograph. So I don't know when her plombage balls were placed, but this was way back when for treatment of tuberculosis. So I'll add that one just so people have more examples. Nothing too special.
Yeah.
But then that got me digging more, and maybe I'll find it. Yeah. And so here, of course, is the one of the other treatments for that. And this one was kind of peculiar because we see this was 2005. And so this is a patient with prior tuberculosis and has been treated with an oleothorax. And you can see the nice fat attenuation of all this stuff in the pleural space. But what was interesting, and this actually prompted further workup, and they actually went in and biopsied, was there was some nodularity to this. And then a year later, even more nodularity in the wall of this cavity, and they didn't get anything out of it. But I thought it was just peculiar. And this, I haven't seen one of these except for ones that have been shown in conferences before. I don't know, David or Howard, if you've seen other oleothoraces.
No, not on CT, no.
Okay, if this is just some sort of granulomatous reaction to this, or what it is, because it turned out not to be.
Why now? I mean, the fact, I would really worry about a cancer developing here.
Yeah.
So you said they biopsied and they didn't get anything.
No, and this has been 10 years or more, and this was kind of the end of his follow-up. and he was 75 at the time. Yeah, I don't know, but they were worried about it for that very reason, that it was new nodularity to this. So I don't know, but that was just a quick one to show. Just another treatment for tuberculosis that I don't know when the last time that was done was. Now this was a case I saw.
Was the material paraffin or beeswax? We don't have any statement about what they pulled off the shelf.
Too old to even get in the electronic medical records. Unfortunately, I have no idea.
Got it.
So here's one. This will be the last case I show, and then I'll let Howard show. This was from the weekend. This was a patient who underwent transcatheter aortic valve replacement last week, and you notice that this is an awfully long, transcatheter aortic valve prosthesis. And when you zoom in, it's not the best radiograph, but you can see that it's a core valve, except it's a core in a core valve.
Yeah.
And it was because the first one migrated. The annulus is down closer to here. You can see some mitral annular calcification. And the first one had migrated into the proximal ascending aorta. And so they were worried about the coronary arteries. They, I guess, did an aortogram. They couldn't cannulate the coronaries, as you'll see on this follow-up CT. Did an aortogram after this, and the coronaries still filled. So they weren't as worried. And then that was on the 20th. Then a couple days later, she's doing worse with the leukocytosis, and she had a troponin elevation as well. They were worried about infection, but as you'll see here, I saw this one this weekend, that this is striking decreased subendocardial enhancement throughout her entire left ventricle. So it's subendocardial, all three vessels, and even her papillary muscles have decreased enhancement. And you can see that her coronaries do opacify. You can see both her left and her right. The one core valve goes all the way up into her ascending aorta, about mid-level at the level of the pulmonary artery. And, so they were going on a working diagnosis that somehow she developed stress cardiomyopathy or Takotsubo from the procedure, except these findings don't really fit with that. In my guess, this is some sort of demand ischemia. Just there must be reduced flow to the coronaries because of this. Her troponin peaked above the limits of detection of the test, and whatever, 70, 80, something. It was too high for them to actually measure it. So she was in some degree of cardiovascular or cardiogenic shock. Her ejection fraction was less than 20%. I guess she's improved some, but this is pretty profound decreased enhancement, like I've shown and others have shown from acute ischemia or infarctions. So this was pretty striking abnormality here, being done looking for source of sepsis, which she didn't have. So I don't know if you have any comments. I know Brent and Art are on there if they have any comments. I texted them a picture of this a few days ago, but.
Do you think the right coronary is involved too?
I think the right coronary territory is involved. Yeah, I think the inferior wall has decreased enhancement as well, and I think that they're still patent. I just think it's slow flow. So I wonder if that's just compromising her perfusion.
Hey Travis,
so, yeah,
it looks like the stent itself. I mean, the valve is partially collapsed. It's too narrow there.
Well, yeah, she has a narrow. So. She has a pretty narrow annulus, and they had put in a 26, and the 26 migrated, and so they then upsized it to a 29 inside of the 26. Yeah, and I agree that but I think it's along the annulus. She had a lot of calcification there too. I've actually pulled up the but you think it's actually collapsed in there, or you just think it's narrowed because of her?
It just looks very narrow, and I just wonder if effectively an outflow obstruction, and so the coronaries are not perfusing as
that's a good point and a good question. Yeah, I don't know. They were just chalking this all up to stress cardiomyopathy, which it's a little bit more than that going on. But I just kind of attributed this to the valve and the fact that it was, well, actually the other valve's not even down here anymore, but just that they had upsized it and it just looks like it should be expanding more. But yeah, that's a good point. Maybe there is some degree of obstruction through the LV outflow tract now.
She looked pretty hypertrophied before, isn't it? So,
right. And this is acquired during systole for the sizing. You can see that the aortic valve leaflets are open. But that's probably just her increased afterload from her aortic stenosis. It's a pretty typical look for these patients. But she has a lot of calcification of her mitral annulus into the mitral aortic intervalvular fibrosa there. So, but hopefully she'll recover. We'll see. All right, Howard.
Oh, okay. All right, let me show you. Let me show you one that sort of goes along with Travis's case. So here is a person that was imaged not at our hospital, but somewhere in February of 15, so some years ago. And there is the finding there. So this opacity in the anterior basal segment, right lower lobe. I don't know what happened subsequently. So the next time something was done or imaged goes now into August of 2016. So let's go back here. And now we're in 2016 in August. And there is that abnormality there, which is a little bit larger. There are also some additional opacities with bronchial wall thickening, airway centric opacities elsewhere in the right lower lobe, but still that thing which is clearly a bit bigger. What happened after that was a CT-guided biopsy was done the following month. So that was done in September, and no malignant cells were derived from that biopsy procedure. No particular diagnosis was made. And then, again, I'm not quite sure about the follow-up after that, but we'll go forward now to April of this year, and you can see that some of the abnormality has gone away, but this thing continues to enlarge. So this is tumor, and it turned out to be a mucinous adenocarcinoma. You can see there that it seems to remain N0, M0. I don't think I have a PET CT to show you, but this is an adenocarcinoma. So it's kind of a slow-growing, rather indolent process, but kind of the usual thing that if you have focal consolidation, maybe he was labeled as having pneumonia somewhere back there, wasn't really followed up. But we're seeing here the natural history of a pneumonia. And of course, CT-guided biopsies are not always diagnostic of the pathology, and this is an example of that. But this is mucinous with mucinous features, some lipidic growth, adenocarcinoma.
So question for you guys on this case, because I think this is a great example. Now, if you were reading the follow-up after the negative biopsy, the CT, how would you word your impression?
If you have the whole complex of stuff, and this thing's really getting bigger compared to before, I think you still have to hint that it could be a, well, yeah, false negative biopsy, right?
Yeah, I think so too. I mean, because we've had these issues come up where I think that usually not this large, but I think the imaging itself is enough to say, this is, despite the false negative or despite the negative biopsy, you still have to consider this adenocarcinoma until proven otherwise.
Yep.
Yeah, and there was a small little nodule in the right upper lobe too, wasn't there, on the most recent one?
Let's have a look at the
little ground glass. Yeah, a couple, or maybe it was right middle lobe. There were a couple small ones. You wonder if those are going to be new foci, mucinous, like that.
Yeah.
I mean, these are the ones, if they go into a wedge or a lobe, then you come back and you have new small little foci that grow over time as well. Or maybe that's just a node along the fissure, hopefully.
Node, yeah. Well, ultimately, this person may be lucky. You know, the lobe has been
Yeah.
taken out now, and if it's N0, M0, and it's this indolent thing, then you're lucky.
Yeah, it seems like we're doing biopsies of some of the smaller ones that, like that one I showed with the fiducial placement that fell into the bronchus, that it's one of those ones that, you know, it's cancer until proven otherwise when they just grow slowly over time and have that morphology. That I hate doing biopsies on those for the risk that you get a false negative.
Yeah.
They just need to come out anyway.
Yeah. Let me show you this one. I've shown these cases before, and this is just to, again, always remain humble. And we know that sometimes even big things are hard to detect. So take a look at those two images. You can see they are quite a few years apart, and see what you see. Anything different on the right, compare it to the left image. And then I will show you the lateral that goes along with the more recent one, which is this one, which really you'd be hard pressed to find something if you didn't know exactly where to look. But here I will show you the extent of the abnormality. So we have an opacity here in the anterior portion of the chest up here, which is up here. And this is the metastasis right here, which is that right hilar and perihilar lesion that's right over here. So this is just a difficult to see carcinoma. I think he presented with metastases, but again, even though this is quite large and the nodal disease is quite large, we're always humbled by how difficult radiography can be. Now that you know where to look, you can see that at least. So just a lesson on hidden lesions that can be quite large and keep us humble. All right, everyone, I think we're done.
Thank you, guys.
Thanks.
Thanks, everyone.
See you next week.
See you next
Bye-bye.
week. Okay, bye, everyone.